It is my absolute pleasure to introduce you to our speakers today. Laurie Beck is the Senior Vice President of Clinical Operations at Aspirion. Laurie and her team of multi-specialty nurses research and write appeals. Pardon me, lost my space here. For both inpatient and outpatient claims, she and her team have routinely successfully overturned denials for a variety of denial reasons, including level of care, length of stay, readmissions, experimental, investigational, and no authorizations. In addition, Laurie has provided both hospital-specific and payer-specific trends related to root cause issues of denials and underpayments. Gloria Sordo is the co-president and general manager of clinical denials for Aspirion. For over 20 years, Gloria has worked with hospital and health system leaders to both prevent and resolve medical claims denials. Prior to joining Aspirion, she assisted in the growth of a startup organization to over 130 staff members, where she managed a team of attorneys who wrote appeals, researched governing laws and/or contract requirements to recover over $1 billion in denied revenue for healthcare providers across the United States. Gloria received a Juris Doctor from Nova Southern University School of Law and a Master of Business Administration from University of Southern Florida, St. Petersburg. She is also an active member of HFMA, AHAM, and AHLA, American Health Lawyers Association. Please join me in welcoming Laurie and Gloria.
Thanks so much, Jessica. Hello, everybody, and thank you for joining us today for our discussion on the 7 keys to preventing clinical denials when subjective decision-making is the cause. My name's Gloria Sordo, and I am the co-president of Clinical Denials for Aspirion. We're a revenue recovery partner focused on complex claims and clinical denials for hospitals nationwide.
Hi, and I'm Laurie Beck. I'm the Senior Vice President of Operations for Clinical Denials here at Aspirion.
Laurie and I have had the tremendous opportunity of working together since 2009, bringing both our legal and clinical backgrounds together to resolve clinical denials on behalf of hospitals. And we're excited to be here to talk about medical necessity denials with all of you today. Our presentation today will focus on medical necessity denial prevention strategies broken into 4 parts. First, we will discuss doing a root cause analysis on a medical necessity denial. Second, we will talk about appeal strategies to prevent future denials. And then we're going to discuss the option of escalating matters through payer discussion, typically JOC meetings and other opportunities. And then finally, we're going to give some examples of educational opportunities we've identified for clients and payers that we work with. However, before we jump into any presentation or discussion about medical necessity denials, we always like to take a moment to review the explanations for denial codes that payers use on EOBs. It gives us a chance to remind ourselves that those areas for a claim denial that involve medical necessity are the types of denials that you want to see. Yep, you heard me correctly, I'm not going crazy. You want to see medical necessity denials. Why, do you ask? Because according to us, this is an area where payers are inviting you to change their mind. The team that developed these claim adjustment reason codes and the explanations for each of the code specifically used that special word in orange, deemed. When they state the word deemed, they drafted these denial explanations in a way that can be determined as a soft word. This word deemed offers flexibility. It's your chance to come in and create a new way of overturning the denial. Deemed is simply an opinion or a judgment. There is plenty of room for interpretation. And because of this soft language, this opportunity to change the payer's opinion should be something that we constantly try with any denial situation, particularly when they're doing authorization denials. It allows us to make the focus back on medical necessity and not strictly the administrative. To begin our discussion on root cause analysis, I want to start with a story. We work with a large community hospital that places their clinical denials with us at day one. That is, any denial, inpatient or outpatient, for either an authorization or medical necessity CART code. We sit on their denial prevention committee, and every other month, we report on what we're seeing as the root cause for the denial. And then we work with their team internally to see what preventative actions can we take to try to avoid these denials. And of course, we track and trend everything. So as part of this tracking and trending, we report back on root causes that stemmed from actions that may have occurred in authorization or in authorization, or maybe registration, maybe system issues with notifications or payer issues. We bring areas to them and highlight patients presenting with the wrong insurance. Insurance was not authorized before the admission. The system didn't do its nightly inpatient census report to the payer, or the payer overturned the denial on peer-to-peer, but didn't up their claims department. And these root cause findings provide action on those details that were administrative in nature. Those denials were to be significantly reduced and some even prevented. But something continued to happen, and it really stood out to us that the biggest denial the hospital was encountering for inpatient claims, represented here by the blue line, were those claims denied for no authorization because the inpatient authorization was denied at the time of request. This was a level of care issue. This involved medical necessity of the inpatient admission. We asked ourselves, what is happening on the front end in the decision-making by the patient's physician to admit, and in decision-making of the payer medical director to say the observation is more appropriate? How do you find a root cause when it becomes subjective decision-making? I'm sorry, Jessica, I forgot the poll. Are we able to do the poll now?
Yep, I'm watching it now.
Sorry.
No problem.
So we've got a poll pop question here for everybody. Okay, interesting. Looks like most of us aren't sure whether or not our contracts allow for medical necessity language. Definitely an opportunity to consider reaching out to your managed care teams to see whether or not you have that language so that you can continue to utilize that rich language in your pursuit of denials against the payers. And then where they may not have it, something to consider for the future. Okay, so we have this question we were just talking about as to how do you find a root cause when it comes to subjective decision making? Well, being a non-clinician tackling this issue, I thought I would start by researching the concept of how physicians are trained to make clinical decisions. So my research led me to this book and called How Doctors Think. And I really thought I had something. That is until I shared with Laurie the book, and she kind of chuckled at me a little bit. And I think it's because she knew the answer wasn't going to be found in this book. While the book had some tremendous tidbits for us to use in our appeals when challenging the decision of a health plan medical director, it didn't really help clarify the concept of physician decision-making, at least in terms of identifying a root cause for a denial. So the quest continued, and we looked at decision-making in general. And we found information regarding people who are considered strong decision makers, that they rarely choose an option based on a single factor. Instead, these individuals indicated taking the best course of action for important decisions entails, with very few exceptions, evaluating multiple objectives, even when those objectives may compete with one another. And if you encounter a decision maker situation where a decision is being based only on one factor, beware. If you look deeper at the decision, you will almost certainly uncover other objectives should also be considered. Taking that information into our realm of clinical denials, we could see that physician decision-making is subjective, in that they too are having to take in multiple objectives as they assess patients, and then interpret and analyze those objectives to render a subjective decision in terms of medical necessity for the plan of treatment. And in theory, this decision-making process should be the same, whether it is for hospital physicians ordering that inpatient level of care, or for the for the payer plan physicians authorizing the admission. So what Laurie, our team, and I came to conclude was that we cannot say why one physician's subjective decision-making led him or her to an inpatient admission, whereas the other physician's subjective decision-making led him or her to say observation was more appropriate. But what we could do is analyze all of these objective items together that go into the decision-making process to see if we can get any insight as to where the denial may have been rooted. We began analyzing different pieces of information that our clinical team noted as they were appealing inpatient medical necessity denials, level of care in particular. At first, it was looking at a lot of text, claim by claim, appeal by appeal, to start identifying the pieces of information that we wanted to track. It took a few months of analysis and a lot of information in order to identify 7 main categories of information that we would classify as objective data elements in this subjective decision-making process. Laurie is going to talk through these categories and will provide some examples of the insight we have captured and reported back to our clients. Laurie?
Thanks, Gloria. So in analyzing level of care denials, to get to the root cause, we have to start where that denial occurred. And usually that is when the hospital's case management team reached out to the payer to request that inpatient authorization. It was at that point, right, that case management would fax over the supporting clinical documentation to the payer so they could make their decision whether or not to grant inpatient authorization. But today, most payers have direct access into the hospital's electronic medical record system, which you would think would streamline the process. But what we have encountered, and perhaps some of you have as well, is where the payer denies that inpatient admission request, stating that the documentation does not support it. You then fast forward to a denial being received on the claim. You submit a reconsideration with the complete medical record, and that denial is overturned, and inpatient authorization is then retroactively approved. So why? What was in that complete inpatient record received after the claim was billed and denied that the payer did not have or consider at the time of that initial request? If you're experiencing something similar to this situation, you have to ask additional questions and investigate to get to the root cause of those denials. Are you sure the payer looked at the necessary information in the record to make a sound decision? Are you able to confirm that the payer actually did review the EMR? Are you able to verify what sections that they reviewed? Some hospitals are able to view this detailed information. Check to see if this is an option in your system, because this is great information to have to be able to hold the payers accountable in their decisions to ensure that they have reviewed all the necessary documentation to make the right decision. In one example, we discovered that a specific payer was not accessing the record after that initial review and approval for inpatient. So the hospital was then receiving these length of stay denials because they weren't accessing for that continued stay review. Do you have too much or too little information turned on for the payer to review and make that decision? We've experienced both scenarios. For example, does the access include the ER records, which is the documentation of the patient's condition at the time of presentation? If not, the payer could be missing that key information to support medical necessity for inpatient, as this is the time when that patient, as you know, is most unstable and supports the need for inpatient care. Is the payer able to view all of the lab, the test results, the vital signs, or are they only getting the physician notes that are available? Although physician documentation is key, specific lab and test results are also necessary to support medical necessity. Is there information turned on that is not relevant to support the inpatient admission? Sometimes when there's too much extra information included, it makes it difficult for the payer and the reviewer at the payer to find the necessary information, again, to make that right decision. And has the payer had a change in staff such that you should offer a refresher training on how to navigate your medical record system so that they know what appropriate sections to look at? Just as hospitals have staff turnover, so do the payers. Has there been training done with the staff at the payer on where to locate the information needed? Is the hospital notified? Are you all notified when there is new staff assigned by the payer to your hospital to help coordinate that training? We also look at the timing of the inpatient order versus the discharge order. When admissions are converted from observation to inpatient, when was that order written in relation to the discharge order? Was it written within hours of discharge or within 24 hours of discharge? We analyzed this data for our clients looking for trends when level of care denials were high. For our hospital client that we talked about at the beginning of this presentation, we found that there was a large volume of accounts denied for inpatient level of care in which that inpatient order had been written the same day or within 24 hours of discharge. In many cases, those inpatient orders were written based on the or the physician advisor's review, but then the attending physician would come behind after that order was written and then discharge the patient. So did the patient really meet inpatient criteria if they could be discharged so soon after the order? For our hospital in our story, when we took this to them, 40% of the level of care denials for one specific physician had that inpatient order written within 24 hours of discharge. We did this analysis over a 6-month period just to kind of put that in reference. We have found that putting a process in place to review those conversions from observation to inpatient when it's done within 24 hours to make sure that that admission does in fact meet inpatient. And if it doesn't, go ahead and get that admission status corrected back to observation before that claim drops. And you should be able to prevent denials by doing that review in advance of actually dropping that claim. One other item I do want to note about the admission status orders: does your claim actually match the physician order? We have seen cases in which the physician actually orders observation and yet the claim was billed as inpatient. Back in my day when I worked as a UR nurse in the ER, it was part of my role to verify that registration entered in the correct admission status based on the physician order. And if it wasn't, I would have it corrected right at that moment. Again, preventing denials in the future. So having your ER case manager or your nurse verify the order and admission status match can help you prevent denials. And of course, we have to look at the rationale for the inpatient admission as documented by the physician. Does the physician's rationale match what is documented in the record? So for example, if the physician notes that severe pain is the reason for inpatient admission or for that patient to stay in the hospital, Yet when you look at the medical record, it only shows that the patient received oral pain medication, medications by mouth, or they didn't receive any medication at all, right? Typically, to meet inpatient, they have to be getting usually more than 3 doses of IV pain medication. Is the rationale only noted in the UM section of your record, or is it documented in the physician progress notes? It's super important that physicians document their thought process and the rationale for that admission and continued stay in the medical record and not just in the UM section. Payers typically do not have access to the UM notes, so they're not getting the full clinical picture or the concerns of that physician. Physician rationale and judgment is a very, very important component to help justify medical necessity, and it must be taken into consideration by the payers. Criteria sets such as Interpol and Milliman Care guidelines, they're just guidelines, but there are other factors, right, that have to be taken into consideration, and one of those is physician judgment. We also need to address the copying and pasting of physician progress notes. I am sure all of you have seen physician progress notes that are literally copied and pasted for subsequent daily progress notes. Sometimes there may be an additional statement of a change, but it's often overlooked because the note mirrors the note prior, and payers are not reviewing for a one-line variation. It's easy to understand why physicians are doing the cut and paste option, given the volume of records that they're completing, but this lack of very patient-specific information often can lead to denials, and it also makes overturning them very, very challenging. Some observations that we've noted in addition is where we had, we were reviewing accounts for inpatient level of care. And of those 13 accounts that we reviewed, 9 of them had no physician rationale noted for why they were converting to inpatient, and the medical record documentation did not meet inpatient criteria. So the physician rationale would have been key to understanding the reason for that conversion. Another example is when a physician is initially an appropriately admitted observation, and then the physician, right, converts them to inpatient, but every progress note thereafter says admitted to observation, right? Because they're doing that cut and paste. So even though it was appropriately documented that first day, once they're converted, that documentation continued throughout that record. Some other examples of weak rationale by physicians would be saying that you're converting that patient simply due to the 2 midnight rule. There still needs to be that medical necessity justification. Patient converted to inpatient due to a change in respiratory or heart rate. Very vague. How significant was that change? Where is the specific details to help that payer understand the physician's concern? And again, as I previously said, that physician rationale has to be in the record and not just in the UM section. Okay, you can go to the next slide, Gloria.
Do you see the change?
Yes, I do. Sorry.
Nope.
So we're going to talk a little bit about peer-to-peer reviews, right? So when the inpatient auth is denied, right, at the time of request, we also look to determine if peer-to-peer was performed. And if not, why was it not performed? If it was done, what was the result, right? Was it overturned? If the answer is no, but we were able to overturn it on written appeal, what is it that we submitted in that written appeal that maybe we could have included in that peer-to-peer to get that denial overturned before that claim actually dropped? On this slide, it shows that only 21% of the denials had a peer-to-peer completed. This data shows an opportunity for potential denial prevention, as well as opportunity for education on what to include in the peer-to-peer discussions to get that denial overturned on the front end. Peer-to-peer reviews are a great option to get an initial denial overturned prior to that claim being billed. If successful, the hospital staff needs to follow up with that payer to ensure that the denial is updated to approved status, as we have often found that the information is not updated in the payer system. So again, your claim still gets denied. It's also important for the UM staff to know which payers even allow a peer-to-peer option and the required time frame for that peer-to-peer to be done. because once that time frame is passed, your peer-to-peer option is no longer an option, and you're going to have to go through that lengthy appeal process. And we should also address what should be included, right, in those peer-to-peer discussions. Physicians need to provide very specific clinical information, such as specific abnormal lab tests or test results, specific abnormal vital signs, lack of improvement with the treatment that resulted in them having to change that treatment plan, as well as, again, their concerns, their rationale, their judgment for that specific individual patient, and all the associated risk factors, including the risk of mortality, in order to help support medical necessity and get them to overturn their decision. Is there a process to ensure peer-to-peers are done when it's available? And are there opportunities to improve that process if it's not being done? Part of our deep dive into these denials was to identify reasons why peer-to-peers are not done. So you can look internally at the processes to see what can be changed. Is it an issue where the payer physician is not available? Maybe you need to set up a meeting, a regular meeting, to be able to have those peer-to-peer discussions. Was it outside the allowable time frame? Was peer-to-peer not an option for specific payers? Is there some dialogue we can have with those payers to make that optional for you? Did the physician refuse, saying it was not appropriate for peer-to-peer? If that's the case, and the physician determined it wasn't a strong enough case, should it remain inpatient, or should you consider converting that back to observation? And the last thing we've noted is miscommunication with the payers, where the team is being told, hey, inpatient's approved, you're good to go. And then when the claim drops, to find out that the authorization was not approved. So that is either a communication issue with the payer, or it could be something internal. But those are some of the things that we would look at.
Real quick, Laurie, it's pop quiz time.
Okay.
So if everybody could take a look at poll number 2.
Okay, so it looks like a lot of you use both Interqual and Milliman Care guidelines, which is excellent because, right, the payers can use both depending on the payer. And then it looks like 39% are not sure what criteria your team is using. So I want to talk a little bit about the clinical guidelines, right? So there's 2 main products available for both payers and hospitals to use to guide them in their decision for level of care. And those are Interqual and also Milliman Care Guidelines, also known as MCG. So first I want to address the criteria and why they are important, right? So both products, right, use evidence-based criteria for determining appropriate admission status or level of care. They also use them for length of stay and for medical necessity for outpatient services, such as diagnostic testing or surgeries. While you would think that both products are similar and have the same desired outcome, there are differences between them, and the hospitals and the payers vary as to which screening tool that they use to make these decisions. When reviewing to determine appropriate admission status for a patient in an acute care hospital, there's 2 factors that have to be met. One is severity of illness. The second is intensity of service. And I'm going to cover those in a little bit more detail here in a little bit. But both of these guidelines do include both severity of illness and intensity of service. It's just that Milliman Care Guidelines, they're focused more on the diagnosis, right, on that severity of illness, and a little bit less on the treatment modalities, whereas Interqual is focused on both of them. You absolutely have to meet both in order to meet that criteria. Please keep in mind, this is like my Bible here, that they're just guidelines and there's other factors that have to be considered when determining level of care. Your risk factors, the comorbid conditions, and again, that physician judgment. The key, regardless of which guideline is being used, is that physician documentation, and it needs to be objective and detailed, providing that specific information to support both of those areas, severity of illness and that intensity of service. The last point I would like to leave you with on this topic is that Medicare does not really endorse either one for determining level of care, right? They use a more vague medical necessity, again, taking into account those other factors that have to be considered. So this is going to lead me into an analysis of the clinical criteria used by the hospital case management team and the payers, right? Again, because they both use a different sets. Is the criteria being used to make that decision correct? And does the medical record support the criteria chosen? In some situations, we've noticed that the payer, in one situation, was using or was incorrectly, I'm going to say, denying claims based on minimum care guidelines. But the criteria was actually met based on the documentation. It was also noted that the physician doing the review did not have that specialty background or experience to conduct that review. So it's important to understand what physicians are doing your reviews, because they should be specialized in that field to make that decision. And then the other situation that we noticed is that they were using the completely incorrect guideline, right? So we all know, right, who's on this webinar, that patients do not come in with just one condition. They often come in with 2, 3, or 4 conditions. The payers focus in on one. And they may be right, it doesn't meet under that criteria, but you know what? It does meet under this other criteria set. So we bring that to the payer's attention to, again, to help guide them in their decision-making process to say, look, you guys are denying these erroneously because you're only focusing on one. So again, we do provide that feedback back to the payers. We also provide the same feedback back to the hospital UR team and their nurses if they're using and interpreting guidelines incorrectly, again, just for training opportunities to work on denial prevention. We have seen opportunities in which the nurses cited criteria that was not supported in the record. And in one case, the criteria chosen was due to it being an inpatient only procedure, which was fine, except that the surgery was canceled and nobody went back to do another review to look to say, okay, is medical necessity still met? They did not have the surgery. Now I'm going to go and talk a little bit about documentation, right? So as for anything, right, for medical necessity denials especially, it does come down to documentation. And that old saying, if it's not documented, it didn't happen, absolutely applies here. So the medical record documentation has to clearly demonstrate that patient's acute condition, including the risk status, including the comorbid conditions, as well as the treatment provided. Again, going back to that severity of illness, how sick was the patient, and also intensity of service, what treatment, right, is being given to this patient. And in order for the intensity of service to be met, it's got to be treatments that cannot be safely provided in an outpatient or a home setting, such as IV medications, frequency of pain or other medications for symptom control other than by mouth, the need for close monitoring, whether that's telemetry or neuroscience or urgent surgery. And the physician's choice of words can lead to a level of care denial. If the physician notes that the patient is being admitted to, quote, rule out a particular condition, the payer is more likely going to determine observation is appropriate for that case. More pointedly, if the physician uses the word observation in their documentation, but then orders inpatient, you can pretty much count on a denial by the payer that inpatient was not needed. I again want to emphasize that the copy and paste function of the daily progress notes, I just cannot overemphasize that here. When there's not updated information in the progress notes and understanding that physician's concerns, it's very hard for the payer to understand the rationale for either admitting a patient or keeping that patient in the hospital, which can lead, again, to your level of care and length of stay denials. And I know that we all understand the challenges, right, with physician documentation, given their time constraints. They've been documenting things one way for many, many years, and now they're being told you have to change how you're documenting. but with a strong CDI team in place, as well as cooperation from your physician advisor, you can make change occur. We recently brought some documentation issues to the hospital. We were telling in our story, we were tracking those level of care denials, and we showed them that the physicians were documenting a lot the word of observation. As a nurse, I understand what he means, right? This patient needs to be closely monitored for any sort of changes, because if something should happen, I need to be able to take immediate action. As a nurse, I know that, right? But to a payer, they're going to cling on to that word observation, and they're going to deny and only approve observation. So getting them to change it from patient requires continued observation to patient requires continued close monitoring for whatever will make a difference in preventing and then getting these denials overturned as well. And in our example, our physician did a lot of training. They included it in the physician newsletter just to kind of get the word out, to kind of change up the wording in their medical record. And then the last thing I want to talk about is communication and process issues. So we look to see if there is an issue within the process. We review for any discrepancy between the physicians and the documentation, any breakdown in the revenue cycle and processes, as well as those payer opportunities. Was the insurance verified? Was notification to the payer done within the required time frame? Were clinicals sent to the payer? Did the payer provide a decision? And if so, were follow-up steps taken if that payer denied the inpatient admission? In the hospital setting, the nurses cannot make the decision for admission status. If an admission does not meet criteria, whether it's interqual or Milliman, those typically go for a secondary review by a physician to make that decision. In our example, 39% of the level of care denials did not have that secondary review done, which I think is so important, again, to try to prevent those denials. If the physician determines OBS is appropriate, was the admission status order reviewed and revised to reflect that change, converting it back to observation? Are admission reviews being done? We did identify a trend for one of our hospitals in which admission reviews were not being done. Were not being done. And when we dug really deeper into that data, we realized that a lot of this was occurring on the weekend staff, when staff is limited. So they were able to adjust their staffing to get more coverage on the weekend so that those reviews could be done, again, in an effort to prevent those denials. Another trend we identified is when a payer does approve inpatient, yay, but then only for a specific number of days. So then not all days are approved. That may be fine if your payer pays by DRG, but what if it hits outlier? And some payers still will not process claims until all the days are approved. So again, it's making sure those concurrent reviews are being done by the payer or the clinical submitted to the payer for review to avoid those length of stay issues. For one of our clients, we did identify a trend in which the payer had a huge increase in their length of stay denials. And again, this is when we looked deeper and realized that the record was not being released to the payer for those concurrent reviews, so they just were not being done. So again, just opportunities to think about for your own internal processes. But the same exact thing holds true for the payers. If it doesn't meet criteria, then the nurses at the payer also has to send those accounts to the medical director for their review and final decision on the correct admission status. And then is the payer not communicating their decision to you, to the hospitals in a timely manner so you can take those next steps to get that denial overturned prior to the claim submission through peer-to-peer, through talking with their nurses, through sending additional clinicals, right? So we also look at those because those are things you would want to bring back to the payer. And then we're going to get right to the denial prevention, right? Those actionable root causes, right? So to get to the root cause of that medical necessity denial requires you to look deep into what happened, look at those objective items that fit into that process. And as we just explained, those 7 areas that I just went through are for level of care denials, because that's what we really focused on. And hopefully you can see that when we started on the left, authorization denied at time of request, that's an unactionable root cause, right? What are you supposed to do with that, right? So we found areas to take potential action, which is listed on the right. both internally to the hospital process, but also externally with your payers to correct the issues, again, to reduce future denials. And the criteria that we review for these types of denials are usually found deep in the medical record and in the hospital case management notes, areas that are not always reportable in the sense that you can just run a report and get it. It takes that more in-depth case-by-case review to get to this level of detail.
Guess what, team? It's time for another pop quiz question. Jessica? Oh, wow. This is a great turnout for this poll question. It looks like it's an even number here on not sures, but most importantly, under 70% or 70 to 90%. Very few in the greater than 90%. So tremendous information for the 64% of us that have a calculation or a metric that we're benchmarking ourselves against. And for those that are not sure, definitely an area that you might want to consider to see how you're tracking or what ways you might be able to begin to track. So that can lead into how you can hold your payers accountable. So talking about appeal resolution and holding your payers accountable, efforts don't only take place by putting process improvement plans into action. Denial resolution through appeals process is also a denial prevention tactic. This is the first place where you have the opportunity to let your payers know that they've denied a claim in error, that the services rendered by the physician to the patient, their member at your facility, were in fact medically necessary. It's you standing up to your payers and saying, nope, you made a mistake and this needs to be corrected. Their error is not only an administrative burden to you, but now they've made it an administrative burden for themselves. To be effective as a denial prevention tool, you have to be strategic about the issues being appealed. Appeal the denials where there is a basis for an argument. Even if inpatient criteria was only minimally met, if you can get an argument in, make it. Yep, I guess that's the attorney in me coming out. But don't just appeal every denial. We have worked with hospitals where their CFOs, CEOs have said, appeal everything. What does it hurt? Well, it actually can hurt your credibility with the payers. Similar to when everything's a priority, nothing's a priority. If you want your payers to take notice of the denials you are challenging on the basis of medical necessity, don't appeal situations where the physician noted that the patient should have been in observation or because of a process issue. The claim billed inpatient resulting in your denial. But appeal denials that have merit and track your outcomes. If you're overturning a lot of the denials you appeal, share that with your payers. Ask them, why are you denying if we just appeal and you overturn the denial? Start a dialogue as to what is going on in their operation causing these erroneous denials and increased administrative burden on both sides. If your denial remains upheld after you appeal, evaluate the merits of the argument for the inpatient admission or the medical necessity of the services provided. If your clinical team is jumping up and down and telling you that these services were clearly medically necessary, keep fighting. The next available avenue is typically to go to your joint operating commission or committee meeting, with the payers to escalate these accounts. Contracts between healthcare providers and payers typically include a provision calling for these joint operating committee meetings. And it gives you additional detail as to a designated time period on where and what you can address, resolving contractual claims issues between the parties. Some of these contracts get real specific as to the type of topics that you can bring to the meeting, such as the first example here. And others are a bit vague, like the bottom example. With the right people brought to the table from both sides based on the agenda set in advance, with claim details provided in advance, these meetings can be extremely effective in resolving problem accounts. For example, we were experiencing a number of level of care denials for one of our particular payers. And even after the denials were upheld, we could see a trend rationale in upholding our denials. It just didn't make sense. So we brought these accounts to one of our JOC meetings, and we asked for the medical director to review the account. He pulled up the accounts in his system one by one and saw that the physician who had signed off on the denial happened to be with a vendor and didn't really have the clinical expertise that was needed in order to make a final determination on the appeals. So the medical director agreed to re-review our appeals himself, and he came back and on 87% of the appeals we filed, he overturned and agreed with the original decision. Again, pushing back to make sure that the reviewer at the payer is appropriately credentialed. Make sure that you're communicating your position verbally. It matters. And we know that hospitals utilize their provider relationships and JOC meetings differently. Some hospitals have a very engaged managed care team to assist, and others do not. If your hospital is not leveraging the JOC meetings as a means of working out clinical denial issues, you're missing out on a great strategy to overturning clinical denials and preventing future denials for similar issues. Laurie?
Yep, I had to unmute here. So, here are just some examples of steps taken by some of our clients to improve their processes and reduce denials based on the information and feedback that we provided. They developed a daily report, right, to identify those admissions in which that inpatient order was written the same day or within 24 hours of discharge. So that case could be reviewed prior to billing of that claim to determine if the admission should remain inpatient or converted back to observation as medical necessity criteria was not met. Another hospital had revised processes, as I talked earlier, and staffing needs to ensure that all admissions were reviewed within 24 hours of admission to verify that the appropriate admission status had been ordered. They provided additional training for the UR nurses and their case managers to ensure understanding and that the appropriate selection of that clinical criteria was used for determining that appropriate admission status. They provided that physician education on what to include in that peer-to-peer discussion, using examples where peer-to-peer failed to overturn the denial, but then the denial was overturned once the appeal was filed with the complete medical record. And they also provided that physician education on complete documentation and that word usage in the record that helps support medical necessity for inpatient. And then providing the payer feedback when communication to the hospital was not done timely as well, or when they use the incorrect guidelines were used to deny the claim. And as Gloria shared just a minute ago, where they have to have that right expertise, right? So again, that was payer feedback, right, to help improve their own processes, to help reduce those denials for the hospital.
So it looks like we're at time, and I just want to bring closure to our story. That community hospital that needed us to dig into medical necessity denials and find actionable insights, we were able to focus on these objective elements surrounding the level of care decision-making, both internal to the hospital and external to payers, where the hospital was able to see an approximate reduction of 46% in their claims denials related to medical necessity. So thank you for joining us for this discussion on how to bring objectivity to an otherwise subjective matter. If you have any questions, please don't hesitate to contact Laurie or I at the contact information shown here. Jessica, thank you again.
Thank you so much, Gloria and Laurie. We appreciate your time and your expertise on this matter. And I want to just say thank you to all of you who joined us today for this lunch hour webinar. I do want to remind everyone that the presentation is available for download. You should have received an email with that link. It's also in the chat box if you want to go there and take a second to download that now. We will have a recording of this webinar available for you to view afterwards. For certificates of completion will be provided to all who attended today. However, if you were looking specifically for the NASBA or the National Accountancy Board certificates, those will be provided to those who requested it on registration and after we have verified that all 3 of those polling questions were answered. So if you'll give us a little extra time to go through that process, we would appreciate it. I do just want to do a shout out for some dates that are coming up outside of those certification boot camps that we talked about at the onset of this. We also have our fall summit coming up. It will be held September 21st and 22nd. That'll be at the Sheridan Denver West here in Lakewood. So keep an eye out for more information about that. Put those dates on your calendar for now. We should have an agenda and some other cool information out for you soon. You can always find information about our upcoming events at www.hfma-co.org. And with that it concludes our webinar for today. Thank you all so much for sharing your lunch hour with us. And again, thank you so much to our speakers. See you guys soon.